All right. So welcome everybody, and thank you for joining us for the In Case You Missed It webinar. This is our third In Case You Missed It webinar where we present highlights from specific conferences. The way we organize these In Case You Missed It webinars is the Combination Prevention Corps puts out a call to those that are attending the conference and asks the scientists in the Combination Prevention Corps if they would be willing to, when they go to the conference, to choose a couple of very important presentations that they can highlight and we can bring back to all of you who were not able to attend the conference. So we thank the presenters for doing the hard work of attending the different presentations and taking notes and putting slides together and presenting it to all of us who were not able to attend. We have five presenters today from the Combination Prevention Corps. We're going to get started right away. Our first presenter is Dr. Chu, who is an infectious disease doctor with the UCLA Care Center. She is also a Combination Prevention Corps scientist and the CHIPTS Clinical Science Corps Director. We will turn it over to you, Dr. Chu.
Great. Thank you, Kathy. Okay, so I'm going to present today on something that got a lot of buzz in the media, which was presented by Dr. Christian Gabler from Berlin, and it was a person that he called the next Berlin patient, and this was his cover slide there. And so this was a case of a potential HIV cure, and I put cure in quotes because we're careful about how we use that word, but what do we really mean when we talk about HIV cure? We mean really one of two things. One is a complete HIV eradication or elimination, and the other is remission. And so what we start out with is the latent HIV reservoir. So that's depicted here in the circle with the cells that harbor HIV DNA. And then interventions are given, and we're still trying to figure out what those interventions could be that are scalable too, that in the case of eradication or complete elimination, ends up with this empty circle where really we've managed to eliminate all HIV-infected cells from an individual's body. The other strategy is remission, where an intervention is given, and we aren't able to completely eliminate all the infected cells, but we get to a smaller reservoir size, hopefully, less virus, and then manage to, through various interventions, also hopefully boost the immune response that an individual has to HIV so that that immune response can then also control HIV better in the absence of antiretroviral therapy. So the end goal is really the same, which is that people are able to eventually stop HIV treatment and control HIV and not need daily antiretroviral therapy. So in this case, what was presented was it was a potential cure case, and we have seen a number of what seem to be HIV cures to date, and really in individuals who have, some of whom have identified themselves, shared themselves with the world, individuals who had leukemia or lymphoma and needed stem cell transplants or bone marrow transplants for treatment of leukemia or lymphoma. In that setting, receiving chemotherapy, radiation therapy potentially, and then donor stem cells, they have been able to be off ART for years without any evidence of HIV. And so what happens in with these transplants when an individual undergoes a bone marrow transplant? They first get chemotherapy and essentially radiation that really wipes out that reservoir. And then they get donor cells that replace their original cells. And for those donor cells, for those successful cure cases, what has happened is that they're getting donor cells that are essentially resistant to HIV. And that's depicted here, where what they have is what's called like homozygosity for CCR5 delta 32. So CCR5 is a receptor that the HIV virus needs to get into, or may need in many cases to get into a cell. And then what usually happens is that that virus depicted here binds to CD4 and also to the CCR5 co-receptor and then can enter the cell. So in the successful cases to date, the donor cells had two mutated copies of the CCR5 co-receptor, and we each get one copy from each parent. And so they had two mutated copies where you can see here, this hairpin-like structure isn't shown here. That CCR5 receptor wasn't there on the surface to allow the HIV to enter the cell. But most people, so it's really very few people that actually have these two mutated copies and resistance to HIV. Most people have this scenario, which is two functional copies of the CCR5 co-receptor gene. And then in the case that was presented at this AIDS 2024 meeting, the individual actually had one functional copy, normal functional copy, and one mutated copy. And that was what was different. So in this case, and this individual was called the next Berlin patient, with one of the first Berlin patient being Timothy Ray Brown. This was a white man who was about 60 years of age, diagnosed with HIV in 2009 and had a previous negative test in 2008. Didn't start ART or HIV treatment until 2015 around the time of a leukemia diagnosis, and then got a transplant a few months after that. And full donor chimerism means that basically the transplant took, and when they checked, all the cells that the individual had, these stem cells, were donor cells and not the individual's own cells. And this is the punchline, which is that here, what happened is they got their transplant, they were on HIV treatment, their viral load depicted by these black dots here was undetectable on HIV treatment after the transplant. And then there's some music I can hear. Sorry. And then they stopped HIV treatment, and they remained undetectable in their blood viral loads off of HIV treatment, and now undetectable for more than 5 years. And when they looked deep in the reservoir cells, so far they have not been able to find any detectable HIV. So this is an example of another potential cure or remission of HIV by a stem cell transplant, with the main difference being that this was a donor that only had one mutated copy of that CCR5. And so the question is raised as to whether or not this CCR5 status made a difference in the remission outcome, and also if that might open up more donors, because it's so uncommon to have the homozygous delta 32. Okay, thank you.
Thank you, Dr. Chu. Our next presenter is Dr. Kate Duval. Dr. Duval is an associate professor in the Division of Infectious Disease here at UCLA and the Global Health Research Director of the UCLA Global Health Program. Turn it over to you.
Great, thanks so much. Great to be with all of you today. Let me get this in presentation slide. Okay, I'm going to share with you today two presentations from the AIDS conference, much more focused on programmatic implementation science. So first that I'll show to you is called Tough Talks, presented by Dr. Stamp and others. And this was conducted here in the US and looking at are there strategies using virtual reality interventions to improve and increase status disclosure among men who are having sex with men. All right, so just quickly, what was the study? So again, objective here was to test the effectiveness of a Tough Talks intervention, which we'll discuss here in a second. This was virtual reality, an intervention that men could have on their phone as an app, and wanted to see the impact on viral suppression and condomless anal intercourse, or CIA or CAI, at 6 months after exposure and engagement in the intervention. Just to pause here, I think this is really interesting and timely because there is a lot of talk, at least in our sphere, around AI interventions, virtual reality, how it can help augment and improve quality counseling, quality peer interactions for individuals living with HIV. And we'll get into how that played out for this particular trial. So this was a randomized controlled trial, again, enrolling young men who recently had condomless anal intercourse with another man, or an STI diagnosis within the last 6 months. These are all pretty young, 16 to 29 years of age, and living with HIV. So having some need of status disclosure. Again, primary outcome looking at viral suppression and any condomless anal intercourse within the last 6 months after enrollment. And I'll note throughout these slides where I think there are some gaps of additional information that would be helpful. In this case, we don't have process outcomes such as actual exposure to the intervention, actual status disclosure, which is the hypothesized pathway through which the intervention may impact primary and secondary outcomes. So would be great to have that. We don't have that from the AIDS presentation. Okay, what is the intervention? So Tough Talks, again, is a virtual reality app used on phone, and the focus is really around building self-efficacy for status disclosure. They didn't specify if it was primarily status disclosure to a sexual partner or to anyone, but it seems like it is more around sexual partners. There's a lot of different modules and activities. There's a lot of practicing or enacting status disclosure that can happen on the app. I think really interesting, they randomized to 3 arms instead of just 2. You have your standard of care, which is pamphlet style information about disclosure. And then you have Tough Talks, an intervention arm that is participant driven. So they're basically given the app and said, please use this, explore it, and that's it. And the amount of exposure, the amount of engagement is based on participant. And then they have an intervention number 2 that is Tough Talks, but guided or nudged by a healthcare worker. So having 3 interactions with a healthcare worker that is encouraging them and walking them through actually using the virtual reality intervention. All right. So they enrolled a total of 156 men. You can see here, they followed them at baseline. They did also 3 months, and then 6 months is the primary outcome. And you can see retention is fairly high. So we have about 80% with a viral load at 6 months. And our condomless anal intercourse measure is done through a survey, have above about 85% response rate on those. Who are we talking about? Who was in this sample? You can see some information here. I think importantly, again, this is a very young group, median age of about 24. Majority are men of color. Slight majority consider themselves as single. I think also importantly here is we have 76% that were virally suppressed at baseline, so at the point of enrollment. Okay, and then what was the impact or the effect of the intervention? Here we're looking at the 2 interventions, Tough Talk that is participant driven, Tough Talk that is nudged by staff or healthcare workers, and we're comparing both against standard of care. You can see the participant only driven intervention actually had no effect on either viral suppression or on condomless anal intercourse. We do see some impact and effect from the staff-driven for both viral suppression and CIA, but to note, it's a modest effect. Again, we don't have any information on process outcomes, and I think that exposure to intervention, did status disclosure actually happen, would have been very helpful here. Okay, so then just some things I think to think about that is helpful for this group, potentially, certainly folks in the spheres that I work in, is thinking about virtual reality interventions, AI interventions. How do we use them as they become more and more common? Alone, they may not be sufficient, as we see from this trial, and that nudges, additional support certainly may be required to probably encourage uptake. Maybe additional support outside of just these virtual reality or AI interventions as well. And then I think importantly, like we've been saying, need some additional information here. Also really curious on what the role of treatment as prevention is on participant perceptions of CIA and other components of disclosure. Okay, I'm going to present to you one more. This is from a very different setting where this is coming from Zambia and looking at injectable PrEP, particularly CAB-LA. It's programmatic and looking at how it was able to be rolled out and if it was feasible to roll out alongside oral PrEP. And again, I think the really interesting point for this piece, anything that is combining or offering both oral PrEP, injectable PrEP, is thinking about choice of PrEP options and how we continue to build out and understand feasibility of choice and then potential impact. Okay, so what was done, and some of these slides I'm very grateful and to pull from the AIDS presentation themselves. They had some great slides. So this was a real world programmatic, really not even study, but description of a program being rolled out in real life, looking at layering on injectable PrEP, CAB-LA, with existing oral PrEP distribution in Zambia. The data is preliminary that was presented, coming from just 6 distribution sites. And notably, all of the sites that it came from were already kind of strong sites that had what they considered person-centered care services in place. The information that we have available is really looking at CAB-LA distribution versus oral PrEP distribution at within a 3-month period, and then 1-month continuation. And for the CAB-LA, the injectable, they did offer some additional services. So they integrated this alongside oral PrEP completely and did provide some additional client support developed using human-centered design. So a CAB-LA specific counseling package, some peer demand creation within community, and then some specific community support materials that could be taken home. All right, here we see we see our absolute number, about the same number of people took up CAB versus oral PrEP. 70% of those who took up CAB were PrEP naive at the time, and you can see the demographics of the CAB users here. Vast majority were young, adolescent men and women, because of probably who they are targeting with the peer demand creation. Again, still some very key questions to be answered around if PrEP uptake was actually increased by introducing the option of CAB, and if there are key differences in the populations. 1-month continuation, we see the same across CAB and across oral PrEP at about 75%. Really what we want to see here is 6-month continuation. And we know from other studies that it's at that 3- and 6-month mark where we see a real drop off in PrEP continuation. All right, and I think just from here, I'll stop, but really, I think the question is around this idea of dynamic choice. And in this setting, incorporating CAB was feasible. Clearly, there was an appetite for it. What does dynamic choice of PrEP and other prevention efforts look like moving forward? And what is the benefit of this product switching option? Thank you very much.
Kathy, you're muted.
Well, you missed me thanking Dr. Duvel. And now we're moving to Dr. Dubrov, who is a combination prevention core affiliate and an associate professor at the Division of Interdisciplinary Studies at Loma Linda University. Thank you for being a presenter. I'll turn it over to you.
Thank you, and thank you for the opportunity to present. I will stay with the topic of CAB-LA, and both of my abstracts are geared towards CAB-LA. And so first abstract that I would like to discuss is titled Pharmacy-Based Delivery of Long-Acting Injectable PrEP in Kenya, Provider, Client, and Key Stakeholder Perspectives. potential challenges and opportunities. It was presented by Stephanie Roche from Fred Hutchinson Cancer Center. And so here's a quick summary of her presentation. The main question was, what are the key considerations for implementing long-acting injectable PrEP in private pharmacies in Kenya? They found that there is a strong support for pharmacy delivery of Cabolet, and that once providers are trained, there is a confidence on the part of stakeholders and patients in receiving Cabolet from pharmacies. Key areas for actions that were identified is enabling policy, increasing scope of practice for pharmacy, infrastructure, and fair compensation for pharmacies who deliver Cabolet in Kenya. And the importance of this study, it creates or presents a preliminary roadmap for implementing injectable PrEP services in Kenyan pharmacies in similar settings. So as a background, 4 sub-Saharan African countries have approved long-acting PrEP, and more in the process of approval, so there will be more countries. Private pharmacies being considered as venue for maximizing impact of injectable PrEP. This study is a qualitative research with pharmacy providers, clients, and stakeholders in Kenya to identify barriers for delivering and facilitators for delivering injectable PrEP in pharmacy setting. So here's the sample of 3 groups, pharmacy clients, 24, their median age was 25, more than half were women, 83% had secondary or higher education. They were all using PrEP, and at least a third of them were receiving PrEP from pharmacies or were started on PrEP in pharmacies. There were 16 pharmacy providers, median age 35. 63% women, half of them have delivered PrEP, had experience. Their median experience as a pharmacist was 11 years, and 80% had experience in giving injections in pharmacy. And had 9 stakeholders with a median age of 44, 67% women, and they were representing Ministry of Health, pharmacy bodies, and PrEP implementing partners. And so the main findings, they structured them according to CIPHER implementation framework, outer, inner, and settings and individual characteristics, discussing for each for outer setting, they highlighted the importance of developing policies, supporting pharmacies, like increasing scope of practice, and including ART delivery in pharmacy settings, in policies. They talked about financing and government subsidies to support this and making economically viable for pharmacies. And they considered that government should be involved in generating demand for injectable PrEP to instill confidence in clients that pharmacies are a good place to receive this prevention method. In inner settings, they talked about equipping pharmacists and pharmacies to deliver this intervention. For example, refrigeration was mentioned as key, and not all pharmacies had it. Establish procurement and waste systems, and create referral mechanisms, especially referrals to virtual remote providers for warm handoffs of patients. And in terms of individual characteristics, clients discuss cost, privacy, and comfort receiving this intervention from pharmacists. They were talking, for example, that some clients would prefer pharmacists to be the same gender. They talked about concerns about site of infection, especially in injection, especially if it will be delivered in abdomen, and as 6 months injectable potentially could be, and having confidence in pharmacists to offer this. And pharmacists discussed importance of training to have confidence delivering this, and fair compensation. The presentation provided 2 frameworks, expedited implementation, where on one side, what governments can do now as they build this program, they could focus on several key areas. to expedite this implementation in pharmacies while also focusing on long-term implementation goals, creating guidelines and essential medicine list and enhancing scope of practice. So kind of two tracks where governments in Kenya can start implementing long-acting injectables in pharmacies. The second presentation I wanted to highlight is the simplest way to go, mixed methods analysis of why women who inject drugs selected long-acting injectable cabotegravir instead of daily oral PrEP, and was presented by Alexis Roth from Drexel University. The main question for this presentation was, when women offered long-acting injectable and oral PrEP, which would they prefer and why? The key finding was that nearly all participants chose long-acting injectable PrEP, with 95% returning for their first injection. And the importance of this presentation was that the strong preference for long-acting injectable PrEP underscores the need for patient choice in care and highlights the urgent need for greater PrEP access for this population. In terms of background, is that HIV cases from injection drug use rose in 2018, first increase in 20 years. And we don't know really much about women who inject drugs and their preferences for PrEP. And there is limited real-world data on PrEP choices, which this study aimed to fill this gap. They recruited participants from TRS, an ongoing RCT in Philadelphia, to reduce risk among women who inject drugs. Inclusion criteria was cisgendered women over 18 with history of injection drug use within 6 months, and they received PrEP prescription within 30 days. They enrolled 104 women. Their median age was 42, and it was a very diverse sample, with 69% being homeless, 81% had overdose history, 23% had PrEP experience or received PrEP already, 74% of the sample injected daily, and they had also 34% shared syringes and equipment. So the findings from this study was that 96% of women with prior PrEP experience chose Cabolet, and nearly all women initiated PrEP. There were no demographic factors or characteristics that influenced their choice. Women's choices were driven by perceived HIV risk, potential adherence challenges, for example, addiction severity, the counseling they received. They were mostly receiving counseling from harm reduction sites, where they noticed how it was shared decision making and a lot of lack of stigma and a lot of respect being offered. And they also talked about their prior medication experience. Those who chose Cabolet, they valued reducing daily action for long-term prevention. They talked about inability to follow through with daily oral PrEP, and they were doubting daily adherence. And so in conclusion, nearly all women who inject drugs preferred Cabolet, indicating strong favor for this option, and offering a broad range of options may boost uptake, similar to trends in contraceptives. Thank you.
And thank you, Dr. DeRoth. Our next presenter is Dr. Cheng-Chin Lin. Dr. Lin is the Methods Core Associate Director here at UCLA CHIPTS and an Associate Professor in Residence at the Department of Psychiatry and Behavioral Sciences here at UCLA. And I will turn it over to you, Dr. Lin.
Sorry. Hey, thank you for inviting me to be here to share some of the important new technology-driven studies that was reported in the IS conference. I will present 2 studies. So the first one is about using AI-driven smartphone app to promote HIV testing in Malaysia. As a little bit of background, the men who have sex with men in Malaysia is facing high level of stigma and criminalization. So mHealth has the potential to reduce some of the barriers and promote HIV testing. So fortunately, the mHealth interventions are feasible because in Malaysia, there's a very high smartphone penetration, and social network apps is very popular among men who have sex with men. So this study used AI-based in-house intervention, which offers more advantage than those manual-based social apps, because it provides more automated responses to some of the unexpected questions from the end user. So the study is funded by Poverty International Center under a R21, R33 mechanism. The R31 phase aims around develop and pilot testing AI chatbot named MyTechSpot to provide information on HIV testing, mental health. And then users can order free HIV testing kit directly from the app, and then be connected to some of the MSM-friendly clinics. So the development phase involves mixed method research to identify contents that needs to be embedded in the chatbot, as well as the right social media apps to deploy the app. And so working with a team of engineers, the app was developed and then underwent alpha testing within the internal team members, as well as beta testing with a small number of end users, which is men who have sex with men. So currently the team is conducting a national observational study among 300 some MSM to further understand their user experience and fine-tune the app. So the next phase will be a hybrid type 1 trial in W3 with about 300 patients to evaluate the efficacy and implementation outcomes of MyTechSpot for HIV testing. So this is a very brief overview. The presenter also briefly discussed some of the his other studies using new technology. So similar to the Malaysia chatbot, he also developed a chatbot to promote PrEP awareness among MSM in the United States. And he also used the augmented reality to prevent HIV among young women, adolescent girls, to prevent HIV in Canada, and then virtual reality study to prevent to promote HIV treatment adherence to prevent cardiovascular co-occurring conditions among patients with HIV, where patients can visualize the blood vessel changes due to non-compliance. So I shared the presenter's information and some of the relevant articles here for those who are interested. So the second study is using artificial intelligence to select the right drug combinations for certain treatment conditions. So this study was conducted in Singapore. So it was so an AI platform was developed to choose the right drug combinations in response to COVID. So the idea is that single drug is sometimes leads to resistance and rebound, and then drug combinations is more effective and provide like lower toxicity, prevent resistance, but the traditional human approaches to design combinations can be very time consuming. So the AI can be used to facilitate the process to select not only the right pair of drugs, but also the right dosage. So this platform is called Ident.ai. So the basic workflow looks like here. It's showed in this figure. It starts with working with clinical experts to select the pool of drugs and then prioritizing it to about 50 or 150 combination of possible drugs. Then use AI to look at the biological correlations between drug combinations and laboratory responses within a set of prospectively collected laboratory data, and there's some final validation status. So basically, these figures here are response service from which they identify BIDD and 1931 as the base background drug for a variety of COVID variants. So they the presenter highlights some of the advantages of using AI to identify drug combinations. First of all, it's highly adaptable, and then you can quickly adapt it to any health conditions. So it's very relevant in terms of responding to a pandemic, and then it involves the input of clinical experts. So the drug combinations will be clinically relevant and feasible, and it's also highlighted that this can help to select not only the right combination of drugs, but the optimal dose ratios. And this AI platform can also be used to resurrecting some previously failed medications, and then suggest alternative drug combinations for antimicrobial resistance, and even used to find the optimization of various weight loss strategies. And I also list the presenter's name and the relevant publications in here. So yeah, I'm really excited to see all these AI advantages. AI development in the HIV/AIDS field, and then I believe there are more to come in the future. Thank you.
And thank you, Dr. Lin. Our final presenter is Dr. Rafi Landowitz. All right. Dr. Landowitz is the CHIPTS Center co-director and also the Combination Prevention Core co-director. Dr. Landowitz is a professor of medicine at the UCLA Care Center.
Thanks, Kathy, and thanks everybody for joining this afternoon. I'm going to try very rapidly to go through 3 studies, which I know is a tall order. First study is I'm going to cover is one of the studies that got the most attention probably in the entire conference. It was called PURPOSE 2. That's a typo actually in the title here. Is the purpose, sorry, so no, it's not, I lied. Purpose 1, sorry. Purpose 1 was a study of, it was a PrEP study of every 6-month injectable Lenacapavir among cisgender women in Uganda and South Africa. And it was compared to daily oral TAF-FTC, which is the drug that we call Descovy in this country. And there was a standard of care control arm, which was FTDF, which is the drug that's formerly known as Truvada. So nobody got a placebo in this trial. So the study design is shown here. These were at-risk cisgender individual women who had not had HIV testing in the last 3 months and were not currently taking PrEP. If they met the eligibility criteria, they entered a randomized cohort where people were randomized 1 to one of those 3 interventions that I told you about. And if they tested HIV positive, they contributed to a counterfactual background incidence estimation that used a controversial method called a recency assay. This is because it is no longer ethical to do placebo-controlled trials in the PrEP space because we have so many effective agents that people are trying to figure out how to get essentially a calculation of what's called counterfactual placebo-controlled estimates of risk reduction that these PrEP agents can give you. So people were followed until 50% of the population had reached 1 year. Sorry, so everybody had at least 1 year of follow-up, and 50% of the population had 2 years of follow-up. That was a pre-specified endpoint at which a data safety monitoring board met and reviewed the results. So these are the characteristics of the population that they enrolled. You can see that overwhelmingly this was a young population of cisgender women in those 2 countries. You can see the racial breakdown. That's because it was done only in the African continent. You can see the educational level and their baseline rates of STIs, showing a highly sexually active population. Very few of them had a prior history of PrEP use. Most had been HIV tested at some point in the past. And you can see the duration since their last HIV test. They weren't allowed to be on PrEP and they weren't allowed to have been HIV tested in the last 3 months because the recency mechanism breaks down if those conditions are not met. So that's why those were part of the entry requirements. These were the results. So this counterfactual background incidence came up with an HIV incidence of 2.41 per 100 person years. And you can see in the Lenacapavir arm, which is this subcutaneous injection given every 6 months, there were no infections that were detected in the follow-up period. I'm going to have you look at the gray bar over to the right. So the control arm, this standard of care artist formerly known as Truvada arm, the incidence rate was 1.69, and that was not statistically different from the background rate of 2.41. In the FTAF, which is the Descovy arm, which has not previously been studied for vaginal exposures, the HIV incidence rate was 2.02, which was also not statistically different from the background incidence rate of 2.41. So it was deemed a huge success for the Lenacapavir arm and a huge failure for the TAF FTC arm. So this is what came out of the risk reduction estimates using incidence rate ratios. The Lenacapavir is in blue at the top. You can see the incidence rate was 0 with an upper 95% confidence interval of 0.04 per 100 person years. Sorry, 0.04 risk reduction, so a 96% risk reduction. And the FTAF, the point estimate was a 16% risk reduction that crossed 1, so was not statistically significant. In terms of compared to incidence in the FTDF group, and that's the control arm, so that's an active control. You can see here that also the FTAF was not statistically significant from the standard of care arm either, but neither were deemed effective. So you might wonder about the tolerability. These are the injection site reactions. No injection site reaction is green. A grade 1, which is a mild reaction, is in yellow. And a grade 2, which is a moderate reaction, is in orange. So you can see the types of reactions. They were very infrequent. It's very interesting that these reactions were reported very infrequently. Most of these actually were assessed objectively, except for the pain component, which was a subjective assessment on a patient-reported outcome form. There were a fair number of pregnancies in this study, unsurprisingly, as contraception was actually not a requirement of entry in the study, which is the first time we've seen that in a phase 3 PrEP study. So that's really exciting. And you can see a large number of pregnancies and happily a very small and not different rate of adverse pregnancy outcomes among the arms, which is really salutary and really exciting to see happening in a phase 3 PrEP style trial. So the conclusions of the study, and I have lots of opinions about this. I'm happy to answer those, share those opinions and questions, but I'm going to try and be objective here. There were 0 reported HIV infections among the cisgender women who were receiving this every 6 months subcutaneous injectable PrEP. So that's very exciting. That protection was superior both to background HIV incidence, which is a novel mechanism of conducting these PrEP trials where you can't do a placebo arm, and the standard of care. Adherence in both oral arms was bad. Sorry, there's a typo there. Should be FTAF in the second one. Adherence to both products was poor. Lenacapavir in the study was safe and well tolerated, but there's an asterisk there because there was really limited time follow-up. And now all trial participants are being offered open label lenacapavir as it continues. So this counterfactual comparator study design is as yet untested in regulatory submissions. So we don't know if this is actually going to be successful at leading to a regulatory approval, and has a number of other methodologic challenges. And they did not interrogate Levi syndrome. So we have no idea what's going on under the hood about whether these long-acting injectable agents are actually suppressing detection of breakthrough infections. And it'll be very interesting to see with longer-term follow-up if this 0 infection estimate actually holds up as follow-up goes on longer. Okay, next study. Full disclosure, I'm biased. This is a study that I presented at the conference. Really looked at the characteristics of using viral load screening to detect breakthrough infections on long-acting injectable PrEP, in this case, cabotegravir, which you've heard about in a number of the other presentations. So this is from the HPTN 083 study. The study design is shown here. I think you're all familiar with it. It enrolled cisgender men and transgender women in 43 sites in 7 countries globally. It was stopped early in May of 2020 for superiority of the cabotegravir intervention compared to daily oral TDF FTC, and then continued in an open label extension. What this data presentation was about was the observation during the blinded study period that using conventional antibody antigen testing and rapid antibody testing alone was not good at detecting breakthrough infections on long-acting injectable PrEP. That's the Levi syndrome. So that's what I'm saying was not done also in the Lenacapavir Purpose 1 study. So in our open label extension in 083, we actually used viral load or RNA testing prospectively to determine if we were better at detecting HIV infections that were breaking through long-acting injectable PrEP. Here you can see the characteristics of the population. In the interest of time, I'm not going to go into this unless people have specific questions. And here are the results. So in the open label extension of 083, there were 26,528 visits conducted where we did an RNA screening test to test for PrEP breakthrough. 73 of those visits, that's a very small number, had at least one positive test. It was a combination or single tests in isolation. And we had a gold standard adjudication committee that figured out if these people actually were living with HIV, were not living with HIV, or we couldn't figure it out. So 42 of them were adjudicated as HIV negative, meaning the testing was false positive. 2 are still under investigation, and 29 were adjudicated as HIV positive, meaning one of those tests suggested a true positive result. Of those 42 people who were negative, 20 of them, it was not a viral load test that was the false positive test. 22 of them, it was an isolated viral load test that was the false positive test result. Of the 29 who were actually positive, 5 of them were detected by RNA only. 24 of them were detected by a combination of tests. What's really interesting was when you look at those 27 total tests where there were isolated RNA positive results, and this is a big source of contention with current CDC and US FDA recommended guidance that this be part of Cabolet PrEP monitoring. How do you disambiguate these very frustrating isolated RNA positive results? And the answer is, if you're already doing it, you repeat it. And if the follow-up RNA test is negative, 100% of the time that was able to confirm that the person, in fact, was negative, and this isolated RNA result was a false positive result. And if the follow-up test was positive, either alone in combination, that was 100% of the time definitively indicative of a true infection. So that's really helpful guidance for the US context. It does not mean that everybody all over the world should go do an RNA testing, because overall the positive predictive value of isolated positive RNA testing was under 20%. So that was really, it did not perform well, and the message is not go do RNA testing in the context of CAB-LA PrEP. The message is we know now how to disambiguate them. Okay, so that's what I just showed you about the 20%. In the interest of time, I'm going to zip through this and get to the next presentation. I will say the third bullet here is really interesting. So guidelines need revision, and the WHO, which said don't do RNA testing in the first place, is laughing all the way to the bank and said, told you so. Last study I'm going to tell you it very quickly is Doxy PrEP in female sex workers in Japan. This was an observational study. They looked at female sex workers who were given daily oral doxycycline. So this is not Doxy PrEP that we've been talking about significantly in the United States, and is now part of guidelines for at least cisgender men who have sex with men and transgender women, but we're still lacking data for efficacy in the context of vaginal exposures. These are all people who had vaginal exposures. And this is a before and after study. So again, a different intervention. This is daily doxycycline regardless of exposure. But these are the population characteristics, and I'll get right to the punchline. Here are the results. You can see the incident rate ratios here were not statistically significant for any individual STI, but they were for overall STI reduction. So there was about a 2/3 risk reduction in overall STI rates after Doxy PrEP was initiated compared to before. Again, this is a different intervention than the post-exposure doxycycline that is currently recommended by the CDC for cisgender men who have sex with men and transgender women. And we still lack data for Doxy PrEP in the context of vaginal exposures. And also, this is not a randomized trial, so we are awaiting randomized data to be able to generalize the success of Doxy PrEP to vaginal exposures, and also to understand the full risks and benefits of a Doxy PrEP intervention across populations. So stay tuned for more about that. And I will stop there. Thanks so much for your attention.
Thank you, Dr. Landovitz, and thank all of the presenters. We do have 2 questions. Wait, I think okay. Okay, we have 1 question in the Q&A because 2 have been answered directly. Dr. Hardy, would you like to unmute and ask your question to Dr. Landovitz?
Sure. Hi, Rafi. Great presentations. I just want to get your opinion on this, because when one reads the New England Journal article very carefully, especially looking at the figures that are not in the major article, one sees that the HIV RNA testing was done not only at screening, but also at baseline. And in those individuals that were already randomized and dosed in the study, if their baseline HIV RNA was in fact positive, they were excluded from the analysis in the modified intent to treat, which actually showed 4 lenacapavir participants, 2 TAF participants, and 1 tenofovir participant. Do you think it's really valid to say that this study had 0 new infections?
I think what we have seen to date is there are 0 incident infections once people started study product by conventional antigen antibody and rapid test-based assessment. What's going on under the hood with the likely suppression of viremia and this Levi phenomenon that we've seen with other long-acting injectable products, I think remains a story to be told. I will honestly, personally be shocked If the 0 number ends up holding up, nothing is perfect. And especially given the low barrier to resistance that we've seen with this product in treatment experienced patients, I again will be shocked if that holds up. But those are the data that are in the public domain to date.
Gotcha. Did HPTN 083 and 084 exclude those participants, excuse me, who were found to be HIV positive by HIV RNA at baseline in a modified intent to treat analysis?
We didn't do RNA testing at entry. We only did it as part of screening. So no, we did not exclude those people. But if you'll remember, when we presented the original results of 083, we had to backtrack on some of the original infections that we had characterized as incident, because on retrospective testing, those people were found to be positive with fairly high RNA values at the entry visit, again, retrospectively on stored specimens, even though their site-based antigen antibody testing and rapid testing were negative.
And they were not counted, even though they were randomized in the intent to treat analysis.
They were counted in the initial results. We modified it 2 or 3 times back, and the numbers ended up being identical even after all of the modification.
Gotcha. Great. Thank you for that explanation.
Yep.
And thank you for your question, Dr. Hardy. And thank you all for showing up and being part of this webinar. And again, we thank the presenters who went to the conference, selected the presentations. We tried hard to present a diversity of presentations. We appreciate the work that you put into this, and we thank you all.